Welcome to the Lecturio podcast. We are going to unpack electronic fetal monitoring, decode the mystery of that strip, and really break down early, late, and variable decelerations.
Because the goal is to make sure you, as a nursing student, are clinically ready to support your patient when you walk onto that floor.
Right, okay, let's unpack this, because before we even get to reading the strip, we need to understand how we actually capture this data, right?
Yeah, you can't trust a graph if you don't understand the physical tools drawing it.
So true. Let's start with the non-invasive route, which is external monitoring. How does that work?
So external monitoring relies on two devices that are secured to the mother's abdomen with these elastic belts. First, you have an ultrasound transducer.
And that's for the heart rate, right?
Yeah. It uses the Doppler effect, bouncing high-frequency sound waves off the moving valves of the fetal heart to calculate the rate. And then second, you have the TOCO dynamometer.
Which everyone just calls the TOCO, right?
Yeah, the TOCO. It's essentially a pressure-sensitive button resting against the top of the uterus, the fundus. So when the uterus contracts, the muscle hardens and pushes forward against that button.
Recording the frequency and the duration of the contractions.
Spot on.
But that non-invasive setup, it sounds ideal for a low-risk patient. But there's a major mechanical limitation there, isn't there?
Yeah, there is.
Because the TOCO is merely measuring the external hardening of the belly against a belt, it cannot tell us how strong that contraction actually is. It just relies entirely on physics.
That's a great point.
Yeah.
If a patient has a higher body mass index, the adipose tissue acts as a cushion, right? It absorbs the mechanical force before it even hits the sensor.
Oh, wow. So the reading would be off.
Yeah, or if she shifts positions in the bed, the pressure against the sensor changes completely. You get a weaker signal that has nothing to do with what the uterine muscle is actually doing.
So that physical limitation, that must be why internal monitoring exists.
Totally. When external signals fail, or, when a provider needs undeniable data about the true intensity of a contraction, we bypass the abdomen entirely.
With the fetal scalp electrode.
Right? It's a tiny wire spiral that lightly attaches directly to the superficial skin of the presenting part of the baby, usually the head.
That sounds intense.
It is a bit more invasive, yeah. But instead of relying on an acoustic echo like the ultrasound, this electrode reads the actual ECG signal of the baby's heart.
So maternal movement doesn't mess it up.
Not at all. It gives an uninterrupted, highly accurate reading.
Gotcha. And to measure the contractions internally, we use an intrauterine pressure catheter, or IUPC, right?
Yes, the IUPC. It's this thin, flexible tube that slides past the baby and rests inside the amniotic space.
Oh, so we are no longer relying on the belly pushing against a belt.
Right. The IUPC measures the true hydrostatic pressure inside the fluid of the uterus. It calculates the strength of contractions in actual quantifiable units, called Montevideo units.
But I mean, introducing any foreign object into the sterile uterine environment that carries risks, right?
A genuine risk of infection or even uterine perforation. And to even place these devices, the cervix has to be partially dilated, the amniotic sac must be ruptured, and the provider has to perform the insertion.
This is always a balance, the clinical need for perfect data against the risk of an invasive procedure. Okay, so let's assume we have our data flowing, either externally or internally. It feeds into the monitor and creates this dual graph strip. I like to think of it like a complex musical score.
Oh, I like that analogy.
Yeah. So the baby's heart rate is the melody on the top graph, and the mother's contractions provide this heavy bass line on the bottom graph.
That's a really good way to visualize it.
And they aren't just playing at the same time. The bass line dictates the environment. When the bass drops, and the contraction hits, we watch the melody to see if the baby can maintain the rhythm.
And to read that rhythm, you need to master the timing on the grid. The horizontal axis is time.
Right.
One little box on that digital screen or the paper printout represents 10 seconds. So 6 of those tiny boxes make up 1 full minute.
And to make it easier, they put a dark line there, right?
Yeah. The monitor prints a dark, heavy vertical line bordering every 1 minute section.
Those dark vertical lines are basically a labor nurse's best friend. Because they map out a full minute so clearly, you can calculate the fetal heart rate and the frequency of contractions from all the way across the room.
Definitely. You don't need to hover 3 inches from the screen, squinting and counting tiny 10-second boxes when your attention really needs to be on communicating with your patient.
And on the vertical axis, the top graph shows the fetal heart rate in beats per minute, ranging from 30 up to 240. And the bottom graph measures contraction pressure in millimeters of mercury, going from 0 to 100.
That's the setup. But before we evaluate how the baby handles the stress of those contractions, We need to establish their calm, resting state. We have to find the baseline fetal heart rate.
Right, the baseline. How do we do that?
The clinical definition requires looking at a 10-minute window and finding the average heart rate, rounded to the nearest 5 beats per minute.
But you have to exclude the spikes and dips, right?
Yes, you visually exclude the major periodic changes, and you need at least 2 minutes of identifiable steady baseline within that 10-minute window to actually declare a baseline.
And a normal fetal heart rate is incredibly fast compared to an adult's due to their high metabolic demand and smaller stroke volume.
Oh, yeah. The healthy baseline range is between 110 and 160 beats per minute.
So let's talk about the danger zones outside that range. A baseline below 110 is bradycardia.
Which is a massive red flag for fetal hypoxia, meaning the baby's tissues are being starved of oxygen, causing the cardiac muscle to slow down.
Scary stuff. And a baseline above 160 is tachycardia. That could be early fetal distress, right?
It could be, or fetal anemia, but honestly, it is frequently a maternal issue. The baby is immersed in the mother's environment.
Oh, like if she has a fever.
Yeah. If the mother develops chorioamnionitis, an infection in the uterus, and runs a fever, her metabolic rate increases. The baby's environment heats up, their metabolic rate increases, and their heart just pumps faster to clear the heat and metabolic byproducts.
That makes total sense. So once you determine a normal baseline, let's say 140, you evaluate the most critical indicator of fetal neurological well-being, variability.
Yes. Variability refers to the microscopic beat-to-beat fluctuations in that baseline heart rate. And we categorize these as absent, minimal, moderate, and marked.
Okay, I have to push back here on the logic for a second. Wait, so we want the heart rate to fluctuate.
We do.
But if you hooked an adult up to an EKG and their resting heart rate was constantly jumping around randomly, you'd think they were having an arrhythmia. Shouldn't a steady, flat, predictable heart rate be a sign that the baby is calm and stable?
You'd think so. But what's fascinating here is that a flat line is actually one of the most terrifying visual cues on a fetal monitor. Yeah. We want to see moderate variability. That means the heart rate is constantly fluctuating by 6 to 25 beats per minute, above and below the baseline. Moderate variability is the holy grail of fetal monitoring.
The Holy Grail? Wow. Why is that?
It proves the baby has a fully functioning, highly responsive autonomic nervous system.
Okay, but how does fluctuation prove the nervous system is healthy?
Well, the autonomic nervous system has 2 distinct branches. The sympathetic branch, which acts like a gas pedal to speed the heart up,
Okay.
and the parasympathetic branch, which acts like the brakes to slow it down. In a healthy, well-oxygenated fetal brain, these 2 systems are in a constant, rapid-fire tug-of-war.
Oh, the gas pedal pushes, the brakes pull back.
Yes, that microscopic neurological battle creates the jagged, fluctuating line we call moderate variability.
So a flat line absent variability means that neurological tug-of-war has stopped. The brain isn't sending those rapid-fire signals.
Right. The amplitude of those fluctuations becomes undetectable, and this suggests severe hypoxia or acidemia.
Acidemia, meaning the oxygen deprivation has gone on so long that the baby's cells are forced to use anaerobic metabolism, right?
Yes, which builds up lactic acid, making the blood dangerously acidic, and that depresses the central nervous system.
But wait, what about minimal variability? Just 0 to 5 beats of fluctuation?
That doesn't always equal acidemia. The baby might simply be in a normal sleep cycle, which usually lasts 20 to 40 minutes. Or the mother might have received systemic pain medications like IV opioids.
Because those cross the placenta and temporarily sedate the baby's nervous system.
Right. But moderate variability remains the ultimate clinical goal.
Gotcha. And to give healthcare teams a standardized language, the National Institute of Child Health and Human Development created a 3-tier categorization system, right? The NICHD tiers.
Yes, so category I is your ideal, well-oxygenated baby. Normal baseline, moderate variability, maybe some early decelerations, but no late or variable ones.
Category 2 is indeterminate, right? That vast gray area where the baby might be compensating for stress, requiring you to watch really closely.
And category 3 is abnormal. That predicts compromised fetal acid-base status. This is where you see absent variability combined with recurrent dipping heart rates.
And those dips are the decelerations. So now that we understand the baseline and the neurological variability, we can interpret how the baby reacts when the uterus actually contracts.
Right, when the baseline squeezes the uterine environment, how does the melody respond?
I love that. So decelerations are drops in the fetal heart rate below the baseline, and the shape, the timing, and the duration of the drop reveal incredibly specific details about the physical stress the baby is experiencing.
They really do.
The gold standard memory aid for nursing students here is VEAL EAL. VEAL-CHOP.
Let's run through it.
Variables mean cord compression. Early means head compression. Accelerations mean, okay, late means placental insufficiency.
Perfect. Let's break down the mechanics behind each one, starting with early decelerations. Visually, an early decel is a gradual, smooth decrease in the heart rate that acts as a perfect mirror image to the contraction.
Like a literal mirror image.
Yeah, as the contraction builds, the heart rate drops. The lowest point of the heart rate, the nadir, happens at the very same moment as the peak of the contraction. As the contraction fades, the heart rate recovers.
But wait, VLH-P tells us early means head compression. Why does squeezing the baby's head make the heart rate slow down? The heart is in the chest, not the skull.
It comes back to that autonomic nervous system. When the uterus contracts, it forcefully pushes the baby's head down into the pelvis or against the dilating cervix.
Okay.
This intense pressure alters the cerebral blood flow and stimulates the dural receptors in the brain. This triggers the vagus nerve, which is the main highway of the parasympathetic nervous system, the brakes.
Oh, so when the vagus nerve fires, it sends a signal straight to the heart, slowing the rate.
Spot on.
And because it is a direct mechanical reflex to the pressure of the contraction, the timing lines up perfectly. So as a nursing student, seeing the heart rate dip on the monitor might send your adrenaline spiking, but an early deceleration is a completely normal physiological response. The baby is simply moving through the birth canal.
Right. But late decelerations are a drastically different story. These also look like a gradual, smooth U-shape, but the timing is delayed.
Delayed how?
The heart rate doesn't start dropping until the contraction is already well underway. The nadir happens after the peak of the contraction. The mother's contraction is finishing, but the baby's heart rate is just hitting rock bottom.
And that delay is the hallmark of placental insufficiency. Let's look at the plumbing of the placenta to understand why. The mother's blood and the baby's blood never actually mix, right?
Correct. They meet in a spongy area called the intervillous space. The mother's spiral arteries pump oxygen-rich blood into this space, and the baby's chorionic villi absorb it.
So when the uterus contracts, the muscle fibers clamp down on those maternal spiral arteries.
Yeah, every contraction temporarily cuts off the mother's blood flow to the placenta. A healthy placenta has plenty of oxygen reserve pooled in that intervillous space, allowing the baby to hold their breath, physiologically speaking, during the contraction.
But if the placenta is insufficient, maybe due to maternal hypertension damaging the blood vessels or diabetes, or simply a post-term aging placenta, that reserve is gone.
Gone. When the contraction hits an insufficient placenta, the oxygen supply immediately drops. Chemoreceptors in the baby's aorta and carotid arteries detect the dropping oxygen levels and the rising carbon dioxide levels.
And to conserve energy and protect vital organs like the brain and heart, those chemoreceptors trigger a reflex that drops the heart rate.
Yes. The reason for the delay, why it's a late deceleration, is the time it takes for the oxygen tension in the baby's blood to fall, the chemoreceptors to sense it, and the physiological reflex to kick in.
Makes sense.
And it takes even more time for the heart rate to recover, because the contraction has to completely end before fresh oxygenated blood can slowly refill that depleted intervillous space. Late decelerations are a major warning sign of poor oxygenation.
Okay, so then we have the VEAL and VEAL chop. Variable decelerations, pointing to cord compression. These look completely different from the gradual U-shapes of early and late decels, don't they?
Very different. Variable decelerations are sharp and abrupt, often looking like the letter V or W on the strip.
The clinical definition is a rapid descent taking less than 30 seconds to hit the nadir, dropping at least 15 beats per minute, and lasting for at least 15 seconds.
Right. So the umbilical cord contains one vein bringing oxygen to the baby and two arteries taking waste away. If the cord gets pinched, the thin-walled vein compresses first, dropping blood return to the baby's heart. Then the thicker arteries compress, causing a sudden backup of blood and a massive spike in the baby's blood pressure. Baroreceptors, pressure sensors in the baby's vessels detect this dangerous spike and instantly slam on the parasympathetic brakes, plunging the heart rate.
I want to share a really memorable scenario from our source materials to illustrate how dynamic this cord compression can be. It's not always the uterus squishing the cord against a pelvic bone.
Oh, I know the story you're talking about.
Yeah, picture a baby floating in the amniotic sac. Let's call him Cletus.
Colitis, got it.
So Cletus is just floating around, and the umbilical cord drifts by and brushes against his tiny hand. Now, newborns have a highly developed palmar grasp reflex.
Very strong.
The second Cletus feels that cord, his reflex fires, and his fist clenches shut. He literally squeezes his own lifeline.
Right, and he instantly cuts off the blood flow from the placenta. The baroreceptors fire, and the heart rate plummets in a sharp, variable deceleration.
And because he cuts off his own oxygen, he eventually passes out. And when a baby passes out, their muscle tone vanishes. His little hand relaxes and falls open, releasing the cord.
And blood flow resumes immediately. The oxygen returns, the heart rate shoots back up to baseline, and Cletus wakes up.
Only to feel that cord resting in his open hand, triggering the grasp reflex all over again.
It's wild, but it happens. Variable decelerations can be episodic, meaning they happen randomly, like Cletus grabbing the cord. Or they can be periodic, happening in tandem with contractions if the cord is trapped between the baby's body and the uterine wall.
Recognizing these patterns, understanding the physiology behind early, late, and variable decelerations, that is step one. But when you see late decelerations or severe variable decelerations, you must transition from observation to intervention.
Yes, it is time for clinical action.
Let's talk about that. You see an unfavorable tracing with late decelerations. Your absolute first priority is intrauterine resuscitation. Step one, reposition the mother. You typically want to turn her onto her left side. Why the left side specifically?
Well, a full-term uterus is incredibly heavy. If the mother is lying flat on her back, that weight compresses the inferior vena cava, the massive vein returning blood to her heart.
Which drops her cardiac output.
Yeah, and that directly drops the blood pressure, perfusing the placenta. Turning her on her left side shifts the uterus off those major vessels, maximizing blood flow and oxygen delivery back to the baby.
And for variable decelerations, shifting her position physically moves the baby, which might relieve the pressure on a trapped umbilical cord.
Right.
Step two, turn off the oxytocin. This is often infused under the brand name Pitocin to induce or strengthen labor. I'll play devil's advocate here for a second.
Okay.
If the baby is in distress, do we not want to deliver them faster?
Right.
Why turn off the medication that is pushing the labor forward?
It's a fair question, but you have to remember the contractions themselves are the stressor. As we established, every contraction clamps down on the intervillous space and halts oxygen transfer. If a baby is having late decelerations, they are failing to tolerate that stress. Forcing the uterus to contract harder and faster is like making someone run a sprint when they're already suffocating. You must stop the oxytocin to give the placenta a chance to refill with oxygenated blood, allowing the baby to recover before the next contraction.
That is a great analogy. Okay, step three is administering oxygen. We give the mother oxygen at 10 to 12 liters per minute using a non-rebreather mask. The goal is to supersaturate her red blood cells so that the maximum possible amount of oxygen crosses the placenta during the brief resting periods between contractions.
And then step 4 is considering an intravenous fluid bolus. Increasing the mother's blood volume improves her overall circulation and placental perfusion. But this requires sharp nursing judgment. You're treating a complex patient, not just a monitor strip.
Yeah, the sources emphasize heavy caution here. A massive fluid bolus sounds great for circulation, but you have to check the fluid type. You want lactated ringers or normal saline, not something packed with glucose that will spike her blood sugar.
Exactly. And more importantly, you have to review her chart. If she has severe preeclampsia or a history of congestive heart failure, her vascular system is already compromised.
Pumping in a rapid liter of fluid could push her into pulmonary edema, causing fluid to back up into her lungs.
Definitely. Which leads us to step 5, performing a cervical exam. The clinical rationale here really depends on the deceleration pattern.
How so?
For late decelerations, you need to know if delivery is imminent. A compromised baby, when the mother is only 2 centimeters dilated, means you are likely prepping the operating room for a cesarean section.
But if she is 10 centimeters and the baby is crowning, an operative vaginal delivery might be the fastest route to safety.
Right. Now, if you see variable decelerations, that cervical exam has another urgent purpose. Ruling out a prolapsed umbilical cord.
Oh, man.
Yeah. If the amniotic sac is ruptured, the fluid can wash the cord down past the baby's head. With every contraction, the baby's hard skull crushes the cord against the cervix.
And you will feel a pulsing cord during your exam. That is a massive obstetrical emergency requiring you to physically hold the baby's head off the cord while rushing to the operating room.
It is terrifying, but you have to act fast. And after initiating these interventions, you call the provider with a comprehensive update. You detail the baseline, the variability, the decelerations, the interventions you performed, and the maternal status.
There is one highly specialized intervention used specifically for severe variable decelerations, the amnioinfusion. It utilizes an intrauterine pressure catheter to pump warmed normal saline directly into the uterine cavity.
It is a brilliantly simple mechanical fix. Variable decelerations are caused by cord compression, often exacerbated by a lack of amniotic fluid, a condition called oligohydramnios. Pumping artificial fluid into the uterus literally floats the cord, creating a physical liquid cushion to protect it from being crushed during contractions.
But a vital warning for nursing students here. An amnioinfusion is never a standing protocol you can initiate on your own. It requires the provider to rupture the membranes, place the internal catheter, and write a specific direct order. Introducing fluid into the uterus carries risks of overdistension or infection, so it is strictly a provider-directed therapy.
Well said. So I think we've covered the fundamental mechanics of the gear, the baseline, the variability, and the cord decelerations.
Yeah, let's do a very short, punchy summary to really lock this in. The normal baseline fetal heart rate is 110 to 160. Moderate variability is the holy grail, proving the autonomic nervous system is pushing and pulling flawlessly.
And to read the strip, use VEAL-CHI-P. Variable decels equal cord compression. Early decels equal head compression. Accelerations equal, late decels equal placental insufficiency.
And when you see late or variable decelerations, you start intrauterine or resuscitation. Reposition the mother to her left side, stop the oxytocin, apply oxygen via a non-rebreather mask, assess the need for a fluid bolus, and perform a cervical exam.
Perfect recap.
Keep learning and practicing with Lecturio to build these critical thinking skills so you can become a great nurse.